Kia ora tātou. My name is Pauline Proud and I work with Mobile Health. I'm one of the training coordinators. And it's my pleasure today to introduce our speaker. This is Kate Berridge. Kate is, she's going to speak on increased risk factors associated with obesity with a focus on COVID-19. Kate is a clinical nurse specialist in bariatrics and she's also founder and director of Beyond Obesity. So I'd like to hand over to Kate now.
Kia ora. So I'm just going to get started. So there is a connection to the COVID-19, but I'm going to weave a little story around obesity, COVID-19, why it's a risk factor, but what we can do in the New Zealand situation, because there's a lot of learning from overseas. We obviously haven't had the same numbers that have been seen overseas, but we're seeing a lot of research coming out of places like New York and Italy associated with the impact of obesity. So I'm sort of going to weave a little story in and around there. So yesterday, this wasn't part of my talk, but it is now part of my talk. I saw this particular discussion live. So this lady is part of the English situation and was obviously doing a press conference not dissimilar to what we have here in New Zealand. However, I was really quite distressed with what she had to say, because she basically was saying pandemic or no pandemic, realistically, you're really better off not being obese. And then she was asked, obviously by some media that you didn't hear the question from, but she then went on to say that from her understanding that it is difficult to lose weight and that diets don't work and that you have to make a significant lifestyle change. And I was really distressed about that, because it shows a very clear misunderstanding of both the physiology and the psychology associated with obesity. And it's clear and present. It's exactly what we're seeing globally at the moment. We're hearing from a lot of clients and patients who experience living with obesity that they are actually feeling less safe, and that many are choosing to not connect with health professionals in any way because they're concerned about what they're going to hear about their body habitus rather than how we can impact on their health. So we have a real disconnect, and unfortunately COVID-19 has really put a wedge in a whole lot of work that has been happening for the last 10 or 12 years around the experiencing of living with obesity. So the reality is that obesity is not the choice that it is assumed to be. We have a very dominant narrative, and this is globally, that assumes that skinny is good and fat is bad. As healthcare professionals, we have a very long understanding that being in a body that has a BMI of less than 25 is considered to be healthy. However, the research is really changing a lot of this, but what we see in frontline practice is not congruent with what we're seeing in the research. And there is so much noise around that it has to be about food. It has to be about the diet. There's a lot of, if anyone who's watching this is looking at Twitter, which I actually do, and every now and then I have to step away from it because it's not good for my mental health. But it's important for me to follow it because I see a lot of important trends around what's happening within diet, within food groups, within nutrition, within politics, associated with obesity. And this dominant narrative is that we need to be skinny to be healthy is really not helpful. And we have, at this point in time, 51% of the global population sits with a BMI greater than 30. So if it's really just about personal responsibility and making choices, we wouldn't have 50% of the global population struggling with obesity. And what COVID-19 has done is it's absolutely highlighted the physiological impacts of living with obesity. But what it hasn't done is highlighted the work that has been going on for the last 15 years from people who have obesity as their specialty. And obesity as a specialty deeply understands the physiology associated with obesity as well as the psychology. It is truly a holistic issue, and it's not simply about the food, which I'm going to demonstrate here. So currently, obesity is essentially a perfect storm. There is multiple factors. So if you look at the picture I have here, it is a 1,000-piece jigsaw. It is a 1,000-piece jigsaw that I did, but not during COVID-19. But it shows healthy food, it shows people with different body shapes, and we actually naturally have different body shapes. But as I discussed, the dominant narrative, particularly for women, suggests that we need to have one body shape, and that particular body shape is slim, muscular, and that actually supposedly tells the world of my health. What I know as an obesity specialist who's looking at people's bloods, who understands people's whole stories, that it's not simply about our BMI. It's not health. Health does not mean a number on the scales. If we actually look at the whole value of health, we understand that it's a multifactorial thing, and it's really not just the number on the scales. So what I'm going to show you is the perfect storm associated with obesity and why it is a lot more complex than simply the food that we eat. And we're being very simplistic if we believe that a certain diet is going to solve this problem. But that is where a lot of the thinking is. And many of you will have heard of keto diets or ways of eating, fasting. These are all useful tools, but they are absolutely not going to change the issues associated with a growing obesity issue around the world. So this complexity starts, actually I should have genes above socioeconomic status. It is a genetic issue. And when I first became a bariatric nurse specialist, I would have patients say to me, and this is back in 2007, well, it's in my genes. And as a thin, privileged nurse who had just come off the back end of doing an Ironman, I was incredibly fit. I had a whole lot of socioeconomic privilege. I had white privilege. I had a whole lot of privilege that I didn't understand. So when people said to me, oh, it's in my genes, I used to think, oh, genes schmeens. And actually, in reality, the truth is that we now know that there is somewhere between 300 and 600 different gene representations that will mean that somebody has a predisposition to weight gain. So we see whole family groups that their body habitus is to be in a bigger body. And that doesn't mean to say that they're actually unhealthy. So genes is part of it. And you can't see me, you can see my head, but I'm 6 foot tall. I weigh about 85 kgs. And if you met my 5 siblings, we're all pretty similar. So height and curly hair is absolutely in my gene pool. And actually putting on weight, it takes a lot of work because genetically, I probably don't have as many genes in that as somebody else who doesn't. So somebody who has 600 of those genes or 40 of those genes, that's it's not binary, things happen. So when somebody says to you, I just need to sniff a donut and I put on weight, that is actually a reality. And there are other people, and we all know these people who can eat 10 meat pies, never put on weight. So that's part of the genetic process. And then there's epigenetics. Now, epigenetics are really fascinating, and you can go down wormholes and read a whole lot about this stuff, and I'm just going to brush over the top of it. But essentially, we have our gene sequencing, our DNA sequencing, and on either side of our genetic sequencing is like a negative and a positive. And when something happens in utero or in the environment that turns on a gene sequencing that is there, once it's turned on, it carries on for every generation after that. Now, we see this in obesity because there was a very important study that was done in Holland, in Amsterdam, around about 2010. It was a random control trial where you had 30 people who were related to women who were pregnant in Amsterdam during the Second World War. Now, the important thing about Amsterdam is it is a ring city and it was under siege during the Second World War. So Amsterdam was starving and the rest of Holland actually had some food. So the 30 women who were pregnant during that time versus 30 women who were not in Amsterdam and out of Amsterdam and pregnant. Those two groups of people have been studied. And what we see from the women who were starving in the Second World War, every single one of those babies who were born went on to have issues with weight and weight gain, and every child after that. So it's been represented in that. So what happened in, or what they consider, what they think is happening, is that in utero, because there was not enough food, the 6 different hormones associated with hunger were turned on. And as soon as the child is born, the child is much hungrier than a child who has enough nutrients during utero, which then means that they're going to be hungrier probably for the rest of their life, which means that they're going to eat differently and have different satiation levels. So that's a factor. And the women who were not starving, their children were born of normal weights, didn't have issues with obesity until perhaps down those family lines, somebody had issues with losing weight during pregnancy related to hyperemesis, or they were on a diet, or for whatever reason, there was food scarcity during the pregnancy, and then the same thing happened. So we know that if you have food scarcity during pregnancy, you have a greater predisposition to weight gain later in life. Same happens for babies who were born in neonates, babies who were born within 24 weeks, 30 weeks, and they spend the first part of their life out in an incubator. Later in life, we know that those babies have a greater propensity to put on weight. So it's related to what happened in the earlier time, was in their epigenetics. Then you add into that the obesogenic environment. Now, the obesogenic environment is the environment that we live in right now. In 2020, we have high levels of consumerism and marketing associated with food and food types. Now, we've all seen it during COVID-19. There is this collective self-soothing associated with distress. We've absolutely seen it. And I found it really, really fascinating that in the first couple of weeks when we were going into, oh my goodness, we might need to have 2 weeks worth of food, strangely, the flour, the pasta, the rice was the first thing to go off every shelf. Now, what happened to all of those people who were happily being keto out there, and then all of a sudden, oh, all of the carbohydrates are the first thing to go? So this obesogenic environment is fueled by marketing around what's good to eat, what's not good to eat. And an example would be, several years ago, it was very de rigueur to be in making paleo decisions about what maybe early man was eating, and maybe early man was eating bugs and all sorts of strange stuff. But paleo, aka sort of around about 2016, looked very much like we eat vegetables and we eat protein, and those carbs are really bad. Now, we know that carbs have a greater input as far as weight gain, but carbs are also an important part of a balanced, good diet. But the obesogenic environment has meant that so paleo became really in, and then the next thing we know, we're seeing paleo cakes, we're seeing paleo this, paleo that, and in reality, it's just a way of selling more food in a different way. So our obesogenic environment is related to the foods that we can buy, the abundance of high fat, high sugar food. It's also related to using devices, not exercising as much, not being able to walk around. For example, when I grew up, I'm in my middle 50s, and so it was normal for my mother to send me off down the road, and I would walk for 3 or 4 kilometers to go to the dairy to get some milk, or I would walk 3 kilometers to work. That doesn't happen now. So we have planes, trains, elevators, lifts. We have multiple ways that we are decreasing our movement, and we have multiple ways that we are increasing higher fat and higher sugar kinds of foods. So it's not really just about the fizzy or just about the McDonald's or just about the whatever. Those are a small part of the bigger obesogenic environment. So the next thing to consider is the number of attempts at weight loss. So if somebody has attempted to lose weight and they've only done it once, yay, that's good. We are going to see a short-term weight loss, but we are likely to see over time that weight increase. What we see in people who are struggling with obesity, because of this dominant narrative that says skinny is good and fat is bad, many people are trying to lose weight. My clients, the average of my clients, and I work with 80% of women and 20% men, and when I talk to my patients about when did you go on your first diet, I would say up to 70 to 80% of my my clients started their first diet from age between 7 and 16. So this dominant narrative that says fat is possibly one of the worst things that we can do, because we have implicit bias that says fat people are lazy, fat people don't have willpower, fat people are not caring for themselves. So as a parent, one of the scariest things is to have a child who is putting on weight, because my fear as a parent is that they're not going to fit in, they're going to have issues. So as parents, the intent is to help our child, but psychologically what lands is the child is not good enough. The child doesn't fit in. So what happens is the child will start to do what the adult wants them to do, because that's their attachment. That's who they want to be seen and liked by. So if I need to be losing weight, then that means that's got to be skinny me has to be preferable to fat me. But what we know about weight loss and diet is that the physiology as you lose weight creates a little bit of a problem in the body, and that the body is always going to attempt to go back to what's called a set point. So every time we lose weight, the body works very hard to go back to put that weight on. The person who has lost the weight, has done very well, thinks that they've done very well, and then they'll fall off the wagon, they'll have something to eat, or they'll go back to previous ways of eating, and the weight comes back on. So this is the place where we start learning what's called internalized oppression. So what this means is the external environment says that fat is bad. So when somebody is experiencing life living with obesity, and they're a 12-year-old, a 13-year-old, an 18-year-old, the message is very clear that I'm not enough in this body, so therefore I need to work with eat less and move more. Eat less and move more has been shown to work well in the short term, but not in the long term. The research is very, very clear that we can probably get 10% weight loss and keep that off. Anything more than that becomes very, very problematic. So every time you attempt to lose weight, you can do it because you're essentially starving your body. And then when you try to return to a normal life, or distress happens, which I'll talk about later, means that your body says, well, thank you very much. I'll just put that back in the savings account because you took it all out and I'm not happy about you doing that. So it's really a homeostatic relationship of the body around weight. So we keep our weight similar as we do our temperature. So when we lose it, the body works very hard to get it back to where it belongs. So the more attempts at weight loss you have, the more you start creating problems and you have dysregulation, and the body just keeps on putting slightly more weight on, and you eat significantly less, and it's a real problem. Now, if I had $1 for every patient who has said to me, I can lose weight, I just can't keep it off, I would have quite a nice little savings account. So then we move into childhood trauma. So we know that if somebody has had more than 4 to 5 adverse childhood event, or an ASA, you have a 36% more chance of suffering with obesity. You also have a greater chance of having any kind of addiction, going to prison. The more childhood events and trauma that you have, the more that gets acted out in later life. So I see this very clearly, that childhood trauma doesn't actually need to be really overt. It can be being put on a diet as a child actually creates trauma because the body has not got enough food. So if we think about Maslow's hierarchy of needs, If food is in scarcity, the brain, the primal brain, is always going to work to put enough nutrients into the body. It doesn't know that it's not starving, but it can see abundant food. So it's very confusing. So childhood trauma, the amount of diets you've been on, the early diets that you started, all of this sits together. But that's also about food scarcity. So these two, I've got them apart because food scarcity can come from socioeconomic status. So if you've experienced at any point in time in your life where you've not had enough food to eat and you are starving, that has psychological impacts. But childhood trauma is a separate thing, but socioeconomic status and food scarcity can fit into that, and it doesn't necessarily need to be. So it doesn't mean that anybody who is in a lower socioeconomic situation has a greater propensity for obesity, because we see it right across every single socioeconomic area, but we see a greater obese situation in the lower socioeconomic world. And a lot of that is because of food scarcity. And if you are, in fact, able to afford a better diet, that is easier to maintain weight rather than gain weight. Doesn't mean to say that any of these other factors are associated. One of the biggest issues, which is only just being talked about, and New Zealand unfortunately is behind the 8 ball here, America, Canada, Sweden, Finland, all of the Nordic countries understand weight bias and stigma significantly better than we do here in this country. And it has a huge impact on the long-term ability to gain weight, lose weight, to sit within that space of being healthy because of that stigma. And then lastly is intellectual or physical disability. For example, things like Prader-Willi, that is the person who has Prader-Willi actually doesn't have the ability to have satiation. So they'll just keep eating and eating and eating, and no amount of behavioral changes that you put in place will change that. Physical disability, I think a patient comes to mind who was a New Zealand representative, was doing lots and lots of exercise, had an injury, didn't change the amount of food coming in, so ended up needing weight loss surgery. So there is not one size fits all. People will fit into various different parts of these, and that's what my assessment does when I'm working with a client. I take all of these into consideration so that I understand where a patient is coming from. However, one of the biggest problems here is that 85% of healthcare professionals have a strong explicit bias, assuming that most of our patients who live with obesity, who are struggling with this, it is because they make poor food choices and it's a lack of exercise. So when the message is, please talk to your healthcare professional about your weight, we're actually aiding and abetting greater problems. And I'll give you an example of this. I work in the specialty of obesity. I understand the physiology all the way down to insulin resistance. I understand adiposity. I understand the estrogen. The whole physiology of it is incredibly complex, and I have a really good understanding of it. My GP did some regular bloods for me, and my liver function was slightly up. And it's a very high chance that I probably had a virus, which is why my liver functions were up. But because my liver functions were up, I was freaked. I was like, hell, I know this stuff inside out. Why are my liver functions high? My GP called me in to have a chat about it, and he said to me, now look, thing is, it's probably about your diet. So you really need to go keto. And he had this very serious conversation with me. The guy knows what I do for a job, and he still completely mansplained to me, and GP explained to me that obviously, Kate, you're doing something wrong with your diet, so you need to go keto. Still not sure if I'm going to change my GP or not, but that shows his lived experience, his understanding, his implicit bias associated with being in a bigger body means that he's looked at my liver function tests and decided it's got to be about my food. Now, we did my liver function tests several weeks later. They were absolutely back to normal. I'd gone and got a tooth fix that I knew needed to be fixed. So it's highly likely that that was coming from a possible infection in my mouth, which was creating a change in my liver function. So it's not all about the food, and it's not because your clients who are living in a bigger body are lazy, but that is what happens to so many of our clients when they go in. I have another example. I have a client who really, really wanted to move forward with weight loss surgery. She went into a GP. Her GP was a marathon runner. GP proceeded to explain to her that she really just needed to learn to do more exercise and be like her and become a marathon runner, and that would solve the problem. That doesn't solve the problem. That is not where that patient was coming from. I did a full assessment, and there was a whole lot of other stuff going on for this girl. And she's now too scared to go back to her GP, and her GP point blankly refused to let her go forward with weight loss surgery and would not put a referral in. So we actually have significant issues associated with the implicit and explicit bias coming from healthcare professionals. So essentially, the eat less and move more, which pretty much everyone has heard as being the way to solve this problem, surely it's just about energy in, energy out, is essentially saying to a drowning person, why don't you just swim harder? So it's really not useful. 100% of my clients have attempted in excess between 10 and 300 diets. So when somebody assumes that it's because you are doing it wrong, or you are not eating, or you're eating too little, this creates significant problems. What is now coming out, and from a really lovely Canadian research, it's possible that there is between 60 and 70% of people who live in bigger bodies struggling with obesity actually have eating disorders. And I kind of take it as a given, because if you've been dieting for a very long period of time, you've actually lost the ability to listen to the primal requirements of your body. You don't know when you're hungry. You don't know whether it's head hunger or if it's real hunger, because you've spent so much time trying to change your body that you've actually stopped being able to hear the subtle cues that your body is giving you. So eating disorders within obesity is absolutely rampant. And so when we say to somebody, oh gosh, don't you look great? You've lost so much weight. We don't actually know that we may be aiding and abetting a very significant eating disorder. So not all eating disorders look like the anorexic. Many people living in bigger bodies struggle significantly with the whole spectrum of eating disorders. Now, eating disorders start at one end of a spectrum and come all the way up to another end of the spectrum. So you can have non-vomiting binge eating at this end, and you can have somebody who is anorexic at this end. What's happened here is these eating disorders are just different ways of acting out trauma that has happened in childhood. So there's the genetic component, and there's also the physiological component. So an eating disorder isn't about the food. It's about what is the problem sitting over here. And in reality, most of my clients have some kind of disordered eating, and it is associated to the dominant narrative that says skinny is good and fat is bad. So really just saying to a patient, eat less and move more, is not going to help them. So why have I had this whole conversation before I'm talking about COVID-19? It's actually really, really important. Because what we see in the patient who is struggling with obesity is we see an overactive HPA axis. So the HPA axis is your hypothalamus, pituitary, and your amygdala. And this is the part of the brain, this is the limbic system, the bit in the middle of the brain. So I'm just going to show you on here. So it's this bit here, it's this middle bit here. Most of us at this point in time, sitting here listening to me, are sitting in their prefrontal cortex, are sitting in, there is no fight or flight or freeze going on. There's like, everything's calm, I'm breathing normally, heart rate's absolutely fine. I'm probably somewhere between slightly increased sympathetic nervous system and shifting maybe down into parasympathetic. And as you know, we need to go from sympathetic to parasympathetic, and we go through this process at any time in a day. So when somebody has increased HPA axis activity, it comes from risk, it comes from danger, it comes from fear. So right now, particularly in level 4, if we had some way of measuring HPA axis reactivity, the whole country was sitting in, holy shit, what the hell is going to happen? We had a global shift, and there was true clear and present fear for many of us. What's going to happen to my income? What's going to happen? Am I going to die? A whole lot of really realistic and valid fear. So everybody's limbic systems and HPA axes were going just totally full tit. Now, when somebody is sitting in a bigger body, the whole process of just walking out the front door and knowing that you were being judged because perhaps you haven't got your shit together and you just can't step away from the Tim Tams actually means that there is increased risk-centered HPA axis. So what that does is it takes the parasympathetic nervous system full tit. So I'm just going to show you here. This is called a Weeble Wobble Man. Now I think of a Weeble Wobble Man, and this is homeostasis. Now, as soon as we jump into the limbic system, as soon as there is a risk that is associated from external sources or internal sources, so our thought processes alone can create our limbic system to go into risk-associated hormone and neurotransmitter processes. So if I'm feeling happy, this is where I sit. If there is a whole lot of external or internal stress or trauma, I'm going to go down here. So that puts me high up in my sympathetic nervous system. And so if I do something like take a deep breath, or I have a glass of wine, or I have some chocolate, or I do some kind of distracted behavior to allow me to feel better, to have a whole lot of serotonin and dopamine hits, brings me up to this point and I'm back in homeostasis. So anybody who has increased HPA axis will learn ways of decreasing it. And it's unlikely to be through grounded breathing, learning mindfulness, learning a whole lot of complex strategies. It's going to be a distraction into, I'm going to have a chocolate bar, I'm going to have some bread. Because hello, how many people have seen on their social media feeds, who's making sourdough, look at this bread, look at my baking. That is actual self-soothing. That is, I am getting a dopamine and a serotonin hit from that carbohydrate, which is actually actively reducing me and taking me down into parasympathetic. So many of the ways that people learn to cope with distress is through distraction. So I find that most of my clients have well-learned patterns of decreasing distress through using food. So it's not actually about the food, it's actually about what is happening in the brain in this HPA axis. And the more it is turned on and is regulated, the more cortisol, the more adrenaline goes pumping through our body, the more our body says to our brain, can you please stop doing that? But that has far-reaching effects, because what we know is that over long periods of time, all of these hormones impact various parts of the body, because we are essentially sitting in fight, flight, or freeze 24/7. It means people don't get enough sleep. It means that people have significant anxiety. And all of this impacts on the immune system. So anybody who is sitting in high reactivity actually is immunocompressed. So add that to the obese patient, and this is what we're seeing in COVID-19. We are seeing, and this was a webinar, I stole this from a guy that I went to a webinar. I thought, oh look, that's going to be useful for my talk. So I took a photo. So Sean Morton is an obesity expert from Toronto. And this was his slide that shows that in New York with COVID-19, if we look at this here, people less than 60 years and obese, their outcome is significantly worse. So somebody who is living in a bigger body has the same risk factors as somebody who is older. Now, why is that? Why is obesity a major risk factor for COVID-19? The inflammation from the adipose cells. So that whole cytokinin HPA axis process impacts the whole body. And that means that we are at fight or flight significantly more, which creates our immune system to get tired. It doesn't like it. So the first thing to fall over when we have long-term chronic distress is our immune system. And then things start to cycle after that. But we have plenty of people walking around who are supposedly healthy with this heightened HPA Axis. So that puts you at greater risk. And you know, actually Boris from England, he's a sitting duck, high level of chronic stress, slightly overweight. That's probably why he was a much bigger risk than somebody in a slimmer body who's all zen and doing yoga and all of that kind of stuff. So that's a really important part. So what we see from that whole cascade of somebody being in a bigger body having a reactive HPA axis is that your immune system is compromised, and that also means that you've got way more cortisol, you've got way more inflammation. Now the process around the inflammation comes from cortisol. So cortisol's role in distress is to pump it out so that I'm ready to run around to do all of that kind of stuff. But cortisol has lots of other really important parts and important things to do in the body. And one of those is to deal with and to provide inflammation. So if I've got sore joints or if I've got something that's creating pain, cortisol will come and reduce the inflammation. So what we know is that much like diabetes, if you have overused your level of cortisol, every now and then cortisol just says, you know what, I can't be bothered. I'm just not going to do it. And when you do that, you have systemic inflammation. So when non-COVID people, if we are providing high levels of cortisol for somebody, that inflammation, where is it coming from? We assume it's just coming because somebody might have arthritis, but in reality, these are part of the chronic conditions that are associated with long-term real reactivity coming from their HPA axis. So that's number one. Number two, central adiposity is of greater concern rather than peripheral. So we've got pear-shaped people and we've got apple-shaped people. So men hold their obesity more in their central truncal area because that comes from testosterone, and women tend to be more pear-shaped, and that's actually coming from estrogen. So we know that if you've got a pear-shaped body, that is far less impacting on central adiposity around chronic conditions, diabetes, all of those issues associated with gallbladder, with physical problems with obesity. So those who have central adiposity are far greater likely to get sepsis and these particular group of people. So they started looking at waist circumference rather than BMI. So if somebody's admitted with COVID-19 and they have truncal obesity, they're likely going to have far more problems than somebody who doesn't. And BMI doesn't really become a factor until greater than 40. So if somebody's got a BMI over 40 and they're essentially fit and healthy, but because COVID-19 is a respiratory disease, if you are not able to breathe properly and you've got this whole cytokine storm that happens with COVID-19, that is a risk factor because you can't actually get rid of stuff that's sitting at the bottom of the lungs. So that's one of the other factors. What they're seeing is that a lot of people sitting with bigger bodies have unrecognized heart failure, and until this whole COVID-19 virus happens, a lot of the deaths are coming from unrecognized heart failure associated with living in a bigger body. Patients with obesity are immunocompromised, as I just explained to you. And one of the issues that they're finding is body habitus. So there is huge, from what I'm hearing, the way that people are being nursed in these areas where there's just, health systems are being completely compromised. Huge team nursing, which means that there's rounds of people being needed to be turned. So there is evidence that prone lying is very useful for recovery from COVID-19. However, if you've got a bigger body habitus, you have a BMI of 40 or you're 200 kgs, and I think of one of my clients, care for this patient is compromised. It's difficult. So if you're going to prone lie people who are in bigger bodies, this is really problematic. So it comes back down to the mechanical process of the lungs, and that being in a bigger body is creating significant risk factors for the disease going into that awful space where it just kind of spirals down. So as I spoke to you before about eating disorders, many of our clients living with obesity have underlying malnutrition, and that is related to that whole process of what I've just talked about. So before, a long time ago, when I was bariatric nurse specialist at Counties Manukau, when we first started the process, we used to test every single patient for their nutritional status. We stopped doing that because what we saw, that everybody who was living with a BMI of greater than 40 had lower vitamin D. Every single one of them had lower B12 and B6 and zinc and a whole lot of really important nutrients that allow us to fight infections, that allow us to be healthier. People living in bigger bodies are actually malnourished. So all of these things create, again, this perfect storm as to why people living in bigger bodies have problems with COVID-19. And it's not simply because they are fat or lazy. This is a very complex situation. But what I'm concerned about is the psychological impacts post-COVID-19. So all of that stuff that I've just explained to you is what those of us who work within the specialty of obesity understand. That's all just a given. We understand the physiology and the psychology. That is very complex. No two patients are the same. This is why we say that obesity is a disease, and it's a chronic disease. It's not just the inability to make good food choices. However, most of my patients have the internalized depression that assumes that they are at fault because they just can't make better food choices. So this is where there's a real disconnect. So what I think the psychological impacts post-COVID-19 are going to be for my particular cohort is, unfortunately, and it concerns me greatly, is there's going to be a doubling down related to that dominant narrative. So we've seen people dying because of their body habitus. So therefore, we need to stop being fat, which is essentially what that first slide is that I showed you. And I listened to the woman from England just basically tell England that you've all just got to not be fat, but I'm not going to tell you how to do it. So really, really not useful. Now, again, when I go back to screening, when I first became a bariatric nurse specialist, I used to screen all of my patients for depression and anxiety. I stopped doing it because depression was literally what came first, the chicken or the egg. So literally every single one of my patients would show significant scores on being depressed. Now, what I know about weight loss surgery is that weight loss surgery really helps with depression. It does very little for anxiety. So there's going to be greater depression associated in this particular group. It was already there, it's just going to be heightened. So we have a whole lot of, there's a tsunami of trauma and mental health issues coming our way. Don't ask me how we're going to fix that, but it is a reality. There is going to be less weight loss surgery related to increased risk. Already, I know that anyone who's going forward for weight loss surgery from this point on, once we hit level 2, is only going to be people on what we call the sweet spot. So anybody who is sitting at a BMI of 45, 50, 60, that group is going to be considered too great a risk because of COVID-19. So we've actually just lost a way of improving significant health for a very marginalized cohort. There is going to be greater polarization between healthcare professionals and fat activists, rather than collaboration or compassion, which I'll talk about in a minute. There's a very strong polarization already between fat activists who sit at this end and healthcare professions who sit at this end, who will say that anything BMI greater than 25, you are unhealthy, end of story. Fat activists who say that you can be healthy at every size, and can you please see me? So these two have been like this for the last 10 years. That's going to get worse. I find myself sitting very much in the centrist position and choose to advocate for my cohort, but also as a healthcare professional. What COVID-19 has shown us is that actually, unfortunately, what fat activists are saying is that you can be healthy at any size. You actually can't. So watch this space. It's going to be interesting. But what I am very, very worried about is the governments are going to continue to victim blame the people living in a bigger body, rather than providing strategies, physical and mental health ways of getting people to be healthier without specifically needing to lose 30 or 40 kgs. So this is a space that I'm going to be spending quite a lot of time on in the coming months, I'm sure. Okay, so how are we going for time? Okay, very quickly. how do we form therapeutic relationships with people who are living in bigger bodies? The very first thing we need to do is understand our own bias, both our implicit and our explicit. If we have implicit bias against people in bigger bodies, that is going to impact any therapeutic relationship. So we need to unpack our own stuff. We need to have knowledge around the role external conditioning and physiology play in the relation of obesity, which I explained to you at the front end. Whatever we're doing is not based on fixing a client. When we see somebody in a bigger body, it's not my job to point out to them that they need to be fixed. They're well aware that they are actually having issues. So therefore, we as healthcare providers actually seriously need to work into providing therapeutic relationships that provide empowerment rather than shame. Now, I work very much with compassion. I work with self-healing and teaching people how to be compassionate to themselves, because this has huge impacts on the HPA axis. Sitting in the back of our primal brain is where our compassion, where we feel compassion. Empathy sits in our front brain. So empathy is, I feel your pain. Oh my gosh, that's so terrible. That's not actually useful in a therapeutic relationship. Whereas compassion is a primal requirement, and it says, I see you, I see your suffering, I see this is really difficult. And one of the things that we see in obesity is isolation and not being seen. So compassion is a really important tool, but it's not about, I'm going to fix you. So things like motivational interviewing and acceptance and commitment therapy. I use both of these all of the time, and meaningful change needs to be coming from the person and not from me as a healthcare professional, because I'm bothered about their size. So motivational interviewing, I'll often say to a patient, on a scale of 1 to 10, how much do you want to change? And if somebody says 10, we can work. If somebody says 4, they're not ready. So you can ask those kind of questions in a brief opportunistic intervention and find out where somebody sits. If they're not willing to change, it's not worth going there. But if they want to change, then it's worth thinking about, where can you go with this patient and how do you do it? And I'm very happy for people to contact me for further details around how you do that. Now, I probably don't have time for this last slide completely. What have I got? Okay, I've got 2 minutes to talk about this particular slide. So you'll see that there is a picture of the Titanic.
Kate, we don't have any questions just yet, so you can
go. Excellent. Okay, so this particular slide is how I explain this whole process to my patients. So essentially, this is the Titanic. And we all know that the outcome of the Titanic was pretty disastrous. Banged into an iceberg, and it was pretty crappy. Now, one of the things that I do with acceptance and commitment therapy, we know that values are a really important part. We also know that mindfulness is a really important part. And both of these things are kind of difficult to teach. So I talk about the Titanic. So I explain to my patients, essentially, you're like the Titanic. And in order to move away from the iceberg, so at the moment the Titanic is steaming towards the iceberg. And in order to change direction, we need to change the navigation, we need to turn the ship around, but we also need to know that the engine is running well, that it's cared for, and it's going to be able to power us up and out. However, due to that reactivity of the HPA axis and learning that we can distract from food, sex, alcohol, gaming, whatever, when we feel distressed, we turn and we distract. What we really need to do is turn and look at what the problem is. Most people do the distraction. So I say to my clients, I say, so what would happen if we just shifted a whole lot of the deck chairs around on the Titanic? How much is that going to change us banging into the iceberg? 9 times out of 10 people go, no, nothing. It's not going to make any change. So diets and all of these things that we've been doing to distract, these are the deck chairs. Okay, so it's not about the food. It's about figuring out what your values are, how you're going to turn the ship around, which is your navigation and the governance of the ship, and the engine. So I teach mindfulness skills about how to deal with reactivity associated with the HPA axis, and I teach people to figure out what their values are so they know what direction they're going in their life. what I find is it stops being about the food, it starts becoming about the value of health, and then we can make real change. So there you go, that's me. And this is just a cute little picture from one of the teddy bears down the road for COVID-19. I kind of thought it was appropriate. There you go, I'm finished now.
Okay, Kate, thank you so much. Look, we have got one question from Tracy, and she says, if GPs are reluctant to understand obesity issues, how can patients access you or your department?
I'm a department of one at the moment, but I do other collaboration work. So I have a website, and people can just come on and make an appointment. Just www.beyondobesity.
Beyond Obesity, www.
If you Google Beyond Obesity, unfortunately, my face will pop up. Yeah, and I'm actually really, really happy for individual healthcare professionals to even email me and ask me questions in greater detail, because the really important thing about this is learning the A&P, really. Serious
issues, and it's disappointing. It's always disappointing to have a mirror held up against our profession and see the deficit that exists there for people.
Well, if we really, it's not really a deficit. It's a model that we've understood for a very long time. But and in all honesty, really, obesity as a specialty is really only about 20 years old. And a lot of the research, we know that it takes 10 years for leading research to come out into mainstream. So a lot of what I'm quoting is 10 years old, and I just happened to discover it when I became a bariatric nurse specialist. So you will start to see that in the next 4 or 5 years, we're going to see way more of this stuff coming out. I mean, and it's why Oprah Winfrey, who owns Weight Watchers, has completely reframed Weight Watchers, because the model of Weight Watchers has been in a shame model, which we now know is really, really detrimental to us.
Yeah. I have got one more question come through. Do you think your whole person approach could be beneficial with anorexia nervosa patients who struggle with the weight?
Yeah. Unfortunately, I'm not an expert. I have had anorexia, real anorexia nervosa, and I know enough about obesity, but that's a whole different specialty. But yes, there is a lot of similarities, and there's a lot of stuff overseas of people choosing to be eating disorder specialists, so they go across the whole spectrum. And again, New Zealand, we don't have a lot of these people. They're as rare as hen's teeth in this country.